last week. Yeah, I forgot which day. Okay, so before we continue to the next subsection, which is about historical aspect, let's review again slightly and quickly what we had learned so far in the previous week. So we have learned about the fundamentals of biosignal, so which is defined as the description of a physiological phenomena. Okay, so what occurs inside the body may be very complex. Yeah, contains multiple aspects coming from the heart, from the muscle, whatever, and they are mixed. So we, as the biomedical engineer, try to help physicians discriminate between these different physiological phenomena through the measured biosignals, yeah, which is basically a description. Yeah, see here, with as the name implies, a description doesn't mean sometimes doesn't mean to describe entirely the phenomena that is occurring. So I may describe Ezra, for example, as a girl who has long hair, long black hair, etc., etc. But it never described the actual, right? The 100% Ezra. Yeah. So similar actually. So with with sensors or biomedical sensors, the goal is of course to describe the physiological phenomena as close, as complete, as wholly possible of the physiological phenomena that occurs. So the more that we can measure, actually, the better. That is one. The current paradigm is to measure the whole. So to measure the ECG, EKG, respiration rate, the blood pressure, etc., and then try to reconstruct the physiological phenomena. Because the physician is someone outside the subject patient. Even the subject himself or herself does not really know what actually happening inside him or inside her. Okay, so usually the physician will ask, "What happened to you? What do you feel, etc." Right? And he cannot or she cannot feel describe everything. Yeah, she can only describe to the best she knows. So similarly, with sensor, we try to elucidate more of those phenomena. So it's not just happen when sensors are being found, but even previously, physicians use their own physical senses, like eyes, ears, etc., and to detect the biosignal from the patient's body. This is example, the stethoscope, an example of most common biomedical sensors that physicians now are using, yeah, around the world, even in resource poor region, yeah, because with stethoscope they can detect the bioacoustical sound, which may come from the heart, the lung, the snoring, muscles, etc. So this describe the parts, yeah, in chest piece, yeah, in a stethoscope. And this flow diagram describe the flow of the information from the signal source, biosignal source, which will propagate through the body to outside of the body, then coupling from the body into the sensor part, especially the transducer part that is attached to the body, then conversion. The signal is being converted into electronic signal and then registration inside the measurement system as either as a graph or as a data inside a memory. So we have, for example, here described this flow of biosignal. And then we have learned a little bit about the model of the permanent biosignal with source inside the body. So this is when the biosignal is induced or generated inside the body. For example, the U here could be our heart, could be our brain, could be our stomach, could be the muscles in our limbs, and anything, okay, which is then propagated to the outside of the body, then coupled by the transducer part of the sensor touch the body, converted into the electronic signal. So you can model using electrical network like this. The registered signal A then will be equals to, or the current, yeah, equals to the U according to Ohm's law divided by the impedances. There are two impedances in this model. The impedance coming from the propagation loss inside the body and the impedance due to the coupling and conversion loss at the sensor part. Okay, the losses are usually capacitive ohmic losses. Here, from the registered current, we would like to reconstruct the source of the biosignal. Otherwise, in some application, what we want to know is the propagation loss, the impedances, the Z, the property of the tissue, for example. Another model is when we use active sensor, active instrumentation. The biosignal is generated outside the body, sent to the body, and there will be coupling and conversion loss. Inside the body, it will spread, scattered, reflected, refracted, etc. Yeah, or this phenomena that occurs in wave. The reflected or scattered ones will be coupled to another transducer, then registered. From this registered biosignal, and we also know the applied signal, then we can estimate the propagation loss, the Z, coming from the body. From there, we can reconstruct the physiological phenomena of interest, yeah, due to Z1. So this is the resulting biosignal. The U is known because it comes from our instrument. The I is also known because it is the signal that we register with our sensor. Z2, Z2 dash are also known because these two are the ones in the device, in the instrument. Z1 is not known. Z1 is the one that we want to reconstruct. This is one example. Another example could also include ultrasound, yeah, ultrasound imaging, CT scan, MRI. This one is pulse oximeter. Then one example, also final example that we have discussed last week is that the same model, the same instrumentation model can be applied also for both diagnosis and therapy, where in this case, the therapeutical device will send signal. The diagnostic device will detect the signal coming from the body and then put in a feedback, yeah, a mechanism here, feedback loop. So to control the signal being injected into body. One example that we have discussed last week is insulin pump, yeah, but not open loop insulin pump, but rather closed loop insulin pump, where the sensor detects the level of the blood glucose, then it will send to this pump to send the corresponding correct level of insulin. Okay, so today we are going to go back in time to study how are actually biosignal being measured or recorded or registered in the past time. Why do we learn history? Yeah, so that we know we can appreciate the role of sensor itself, and we will know also how sensors are important to register and record biosignal. Because with the advent of sensors and instrumentation, physicians, the doctors now can get more biosignals, and hence, as I mentioned, the more that we can describe of the physiological phenomena. For example, now using this again, I give example. Let's not Ezra again. Let's say Andy. Yeah, using this. Even now, Andy is turning off his video. I cannot describe Andy. Yeah, I can just describe Andy as four letter ANDY. Yeah. As soon as Andy unmute his microphone, Andy, can you talk a little bit?
Yes, sir.
Now I can describe from his acoustical signal. Yes, sir. Then, Andy, can you please open your video? Now I can describe Andy more. Yeah. But even then, the description is still limited. And now I describe Andy as someone with wavy hair, yeah, with a bit of skinny head, etc. Yeah. But when we can meet Andy, when I can meet Andy in person, then I will describe him more, even more. When I can attach more sensors to his body, then I can describe even him even more. Okay, now you can you can close your turn off your video. So similarly, yeah, previously also physicians are forced to work in blind like this. Like now, I'm seeing you only as your names, yeah, and they try to predict what actually happened inside the patient body just from the patient's feedback or complaint, yeah, or whatever the patient feel. Then with the course of time, they will start, the sensors are being developed, electronics are invented. These electronics and sensors are started to be used also in the medical world. And then physicians, the doctors can know more about the condition of their patient. So that is why what we are going to study now. So this development of biosignal measurement. So the very first biosignal, yeah, this picture already appeared actually in some slides before. So early diagnosis were made on patient's verbal information. So how are you, for example, yeah, the doctor will ask, and what do you feel? Since when do you feel like that? And then based on that information, the doctors will try to assess and evaluate the condition of the patient. Basically, this method is still being used now, yeah, even now. So then inspection is done only by bare eyes of the doctor. So how the patient look like? Yeah, is he pale? Then maybe his color change, his skin color change. Maybe there are some patterns in his skin, etc., etc. Maybe the temperature is different, etc. So inspection is one of the main method that is being used. Even until now, yeah, inspection is something which normally the doctors will do. So patient by bare eyes, the doctor's own eyes. Then after that, physicians, the doctors start to use palpation. Palpation, what is that? So this is the feeling of the surface of the body with the hands. Yeah, with the hands. Yeah, the patients, the doctor will put his hand, for example, at the at the vein of the patient, and then feel the blood pulse. Okay, on if the patients have something, what do you call it, a tumor or something in the skin, the doctor will feel it. Is it harder than the normal tissue, softer than the normal tissue? So the doctors try to determine the size, the shape, the stiffness. Yeah, stiffness is a mechanical property. Location of the organs beneath the skin. This is also done, for example, sometimes when I was kid, and when I go to my pediatrician and my kid doctors, the doctors will put his hands in my stomach and feel whether my stomach is what do you call it, hardened or not, to feel if there are some abnormalities with the stomach. And this is even still currently being used, yeah, until now. So often applying a small amount of pressure to the surface of the skin or superficial artery to partially constrict it. Constrict facilitates an easy observation of mechanical change. Something pushing a little bit and then releasing it, and see how the body will change. The surface of the body will change. From there, the doctors can predict or can estimate what happens there. Yeah. So this is the method called as palpation, using the hands to feel the surface of the body. And this is percussion. The next method, the third method, yeah, after inspection, palpation, then is percussion. In percussion, yeah, sometimes also my doctors, when I was child, put one of his hand to the stomach and the other hand will tap the stomach to see if my stomach has gas, a lot of gases or not. Yeah, so one of the common disease of a child, yeah, usually that there's a lot of gases because the child doesn't want to eat much, and so and instead there will be a lot of gases, and sometimes to the other parts of the body also. So percussion here is the procedure to tap, yeah, striking the body directly or indirectly, short tapping, yeah, or like a hammering strike, yeah, to produce the sound. From the sound produced by this tapping, vibration, the physician can predict what happens in the body. So the sound will be produce resonant or dull character, indicating whether it is hollow or solid inside the body. Is it air containing structure, etc., etc. So the sounds are helpful in determining the size and position of various internal organs, in localizing fluid or air in the chest and abdomen, and in aiding the diagnosis of certain lung disorder. So this is how it looks like. Yeah, this is a percussion method, so similar like percussion music. Yeah, with strike with tapping. Then the last one is called as auscultation, from the Latin word auscultare, to hear attentively. So this is a diagnostic procedure in which the physician will listen to the inner body sound to detect pathologies or the state of the health. In the previous time, this is done usually by putting the physician's ear very close to the patient's body, even touching, like closing the body, closing his or her ear to the patient's body, the patient's stomach, yeah, to listen to the sounds inside the stomach or the patient's chest, to listen to the sound of the lung, for example, and the heart. So the body sound may comprise of the heart sounds due to the closure of the heart valves, or lung sounds due to air turbulences in the branching airways. So this is what Hippocrates said. Yeah? Hippocrates is one of the ancient physicians from the Greek civilization. He said about visual inspection. Yeah? By looking with bare eye, it is necessary to begin with the most important things and those most easily recognized. It is necessary to study all that one can see, feel, and hear, everything that one can recognize and use. So it means that what the first one, the physician will try to study all that he can see, feel, and hear, everything that one can recognize and use. So immediately looking from his bare eyes. So even until now, this principle is still being used by any physicians around the world. Yeah, even at the most developed countries, they will not immediately go to MRI now, go to CT scan. First is, of course, by visual inspection. So this is palpation in the old times, in the Greek method. How it is being used. This is uh, a picture, yeah, when Hippocrates palpating a young patient using his hands, his finger, touching to the patient's body, to the child's body, to feel the mechanical property of the stomach here. So some example, it was used to diagnose the disease of a woman, yeah, the womb, the disease of the woman at the womb, yeah, by putting the hand of the physicians at the uterus, attaching the hands at the artery to feel the arterial pulse, yeah, to indicate whether that person is still alive or not. So Erastus, about some hundreds years before UC, yeah, he is one of the Greek physicians, the father of physiology. He used this method, palpation, to detect pulse in clinical diagnosis. And here, even describing love sickness. Yeah, any of you ever have love sickness? So this is, they describe that time, pulse quickening in the presence of beloved person. Yeah. So when a person is in love with someone, when he is in the presence of the beloved, his pulse will be beating faster. than usual. So this can be detected using palpation technique. Okay. Then a periodic expansion of an artery is felt in response to a periodic rise in blood pressure, the radial artery of the wrist. So this can also, at the time, there is no need for blood pressure meter yet, tensimeter, yeah, or speakmograph. They just use the palpation method by their hand to to feel if the artery at the wrist is expanding or not. If there's some expansion, it means then there might be increase in the blood pressure. Then it continued, yeah. Dr. Auenbrugger, Leopold Auenbrugger. This is in the 18th century, 19th century. This is Austrian physician. He's the one introducing the percussion technique, yeah, the tapping technique as a diagnostic tool in medicine in 1761 in Vienna, Austria. He described percussion as a slow tapping with the fingers brought close together. So the finger is brought close together like this, yeah, and extended on the finger of the other hand, and extended on the fingers of the other hand laid on the chest, yeah, like this. Yeah, and then tapping to that the other hand's finger. So this is disseminated. This was disseminated later by Dr. Jean-Nicolas Covisart. I hope I'm pronouncing the name correctly. In the 18th century, also a French physician of the Napoleon Bonaparte. You know Napoleon, one of the French Empire, yeah, after the French Revolution. And finally, the direct auscultation, which is also actually already suggested by Hippocrates. If you listen by applying ear to the chest, yeah, so Hippocrates said by directly listening to the sound of the body by attaching your ear to the chest, or actually other parts of the body as well. But the body sounds just gained its relevance in diagnosis at the beginning of the 19th century. So previously in the Greek, more of a direct observation and palpation technique was more of significant. Yeah, there's not directly hearing the sound, but feeling the mechanical property of the body using palpation technique as well as visual inspection. Yeah. Then percussions in the 18th century in the Europe by Dr. Auenbrugger, then disseminated by Dr. Corvisart. While auscultation, although already mentioned by Hippocrates, but gaining more of its relevance in the beginning of 19th century. Then the auscultation technique was improved by Dr. Laennec. This is the student of Dr. Corvisart. So Dr. Corvisart is the one that made the tapping technique, the percussion technique, sorry, more widely available, more widely disseminated than his student, Dr. Laennec, Dr. René Théophile Jacinta. A bit difficult, yeah? Like Jacinta, like Ezra's name, Laennec, a student of Dr. Corvisart. He developed indirect auscultation using a wooden cylinder. So initially aimed to avoid embarrassment. So initially, this precursor of stethoscope to hear the body sound is actually not made for the sake of amplifying the sound. Yeah, for the sake of, instead, it was used to avoid embarrassment. So this is why I don't put the picture here. So in something like this, in some patient, yeah, it was the patient was woman. The physician usually at that time were men. Sometimes they were just embarrassed to put like this, yeah, the ears of the physician to the body of the women patient. So this Dr. Laennec invented the precursor of stethoscope made from wooden cylinder like this. Okay, so where do you think is the diaphragm method, the chest piece in this part? Anyone? Grace? Is the chest piece this one or this one? Yeah, this one or this one?
Right, yang gede, sir.
Huh? Yang gede. Okay, the big one. Yeah, yes, it's correct. So this one is the one that is being attached to the patient's body. So it will collect the sound from the patient, then channel it through this tube, long tube, and then the physician's ear, the doctor's ear will be in this side. Okay, so this is how it is made. First, they develop long, one big hollow tube inside this wooden cylinder, and then one part is being drilled further, widened to be made widened to collect the sounds. Okay, then this is how it looks like, yeah, in reality. I'm not sure if we have that in Indonesia. So this is how an illustration how it was used that time by Dr. Leineck. Yeah, this is Dr. Leineck putting the wooden cylinder the earpiece in his ear and the chest piece on the listening piece in the patient's body. Then in the late 19th century, Bianchi from Italy introduced a rigid diaphragm over the part of the wooden cylinder to replace the hollow, the cone shape hole and replacing it with diaphragm. So the diaphragm will amplify the sound further. So this becomes the beginning of the chest piece when applied to the chest. This is reported by Hollins and Rappaport and Sprague in the early 20th century. At the time, so the device is called as Bazzi and Bianchi phonendoscope. 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 Something like that. So it already resembles the current stethoscope. Okay, looks like the current stethoscope here. This is the diaphragm. This is the earpiece. Then, of course, this is what you see today. If you go to clinics and you meet doctors, usually they will have this kind of stethoscope consisting of a bell-type chest piece for amplifying the sound, rubber tube here for the sound transmission, and finally the earpieces for connecting the sounds into the ear. And finally this one, which is still quite expensive, not widely available, the electronic stethoscope. First visual stethoscope. So not only you can hear the sound from the patient's body, but it can also display the sound as electronic graph as a function of time here. For example, here display simultaneous phonocardiogram. Phonocardiogram means the sound of the heart, the sound signal of the heart. Okay, so we have learned that in the history, in the past, people have used these four types, for different methods of biosignal acquisition, in the form of direct visual inspection, tapping, percussion method, direct visual inspection, palpation, touching the hand and to feel the mechanical property of the body, then tapping or percussion method, and to excite vibration into the body and then hearing the response. And finally, auscultation. Auscultation is hearing the sound of the body using the ear directly. Now, the problem of this biosignal acquisition methods, because they are is related with the objective evaluation. Most of these methods are very subjective. Okay, it depends. The signal that you record or the physician record will depend on the physician himself. Whether he has good ear or not, good hands or not. And even within the same physician, the signal being recorded at one time may differ than the next time he recorded that sound with his own ear. Okay, the physician must be also in a good healthy condition in order that it is repeatable. The measurement is repeatable. Otherwise, then one time he will hear the sound of the heart of the patient like this. Dup, 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 dup. Maybe another time different sounds. Yeah? Even though the patient condition is actually still the same. Yeah, and so different time may result in different measurement condition with different measurement result. And then it is very difficult to convey this measurement to other physician, right? Because it is all subjectively perceived by that individual physician, and very difficult to convey the result. How is that patient condition? Yeah, he may be good, he may be right, but how good is good, etc., etc. So this is the problem with the previous all that the mentioned biosignal acquisition methods. They are not objective. They are mostly subjective. How to prove the biosignal? How to analyze the biosignal? How to compare one biosignal from the other, even from the same patient? Today's biosignal with tomorrow biosignal. There's no way because they are not recorded. They are recorded in the memory of the physician. So it depends on the memory, the good memory of the physician. Even then, if he or she, the physician, has good memory, it's not that easy to compare the biosignal of a patient from one day to another. How to circulate the biosignal from one physician to another so that the analysis, the diagnostic can be done together, for example. Okay, let alone to analyze, yeah, because it is not recorded, you cannot do further analysis. All are done individually, personally, subjectively, by individual physician. It is a problem with all those methods, yeah, inspection, palpation, percussion, and auscultation. So the first method is the first problem, yeah, reproducibility of the biosignal observation was not possible because of the observer's variability and no means for the biosignals archival storage, because it cannot be storage, it cannot be stored. As I mentioned, it is here by that person's, the physician's person, subjectively at that particular time, recorded only in his brain. Even sometimes, if he forgot, he cannot reproduce that signal, right? So this one, the result is not reproducible. No means for the to archive the biosignals. Analysis of the biosignal was restricted to an instantaneous impression. Means that impression by the physician at that particular time. Instantaneous impression by the physician. With the impression being strongly affected by the physician's personal experience. Yeah, only by that physician's experience. The more experienced the physician, the older physician usually will have better analysis compared to the young ones. Because, of course, the older, more experienced physician, he or she has heard a lot of different kind of biosignal sounds, acoustical sounds, okay, from healthy people and very sick people. While the young ones may not yet widely exposed to these various types of bioacoustical signal. Then classification of biosignal was impeded by nomenclature difficulties. Yeah, not easy. How to classify? How to classify a biosignal of a sick person? If yes, if we can classify compared to health, what kind of sickness? How severe is that sickness? So this is not easy. Cannot, because it's very subjective. And how to compare two biosignal? It is hardly possible, very impossible, almost impossible, as they were restricted to a single position and recent impression. Cannot be recorded from very old time ago. Circulating the accumulated biosignal data was also impossible because the lack of archive. Yeah, because it is stored in the memory of that particular physician. Okay, not with everyone else. So the solution at the time, it doesn't mean that all physicians think they did not think of how to solve this problem. They already think some of the solution to this problem. They try also to objectify and characterize the attained biosignal given roughly in chronological order. Yeah, here. First is using verbal description of the signal itself. But this verbal description may also differ from person to person, from physician to physician. They may use different verbal description. Even then, if you describe verbally a sound using the same description, let's say you use like the sound of the morning bird chirping in the morning. For example, this is a description. The morning birds in my house may be different than the morning birds in Ezra's house, right? For example, so the chirping of the bird may be different. So this verbal description also is not repeatable. Then they start to use different way using musical notes. Yeah. So this is better, actually, much better, because then it is more quantitative. The note in it is, if you play music, I don't. It is based on certain note, and then the certain frequency of sound is being described as with certain musical note, either as letter or a symbol. Yeah, in the what do you call it? In the musical partiture, yeah, and if you have multiple frequency happening together, you put it as like an orchestra notes, for example. After which, then this is the beginning of biomedical instrumentation. Physicians start to use technical tools to record the biosignal. Okay, so with the verbal subject, it is very subjective, still strongly subjective, as I mentioned. The description of the sound of the water when there is a wind, that sound may be different, perceived by me and perceived by Andy. So the impact is that it is still qualitative. And when they start to use musical notes, then the subjectivity decreases. So it's getting better. So it is more objective now. But it is still a little bit qualitative and quantitative. For example, with the same note, different musician, for example, even playing the same musical instrument, may give his or her own personal interpretation of the note, right? Sometimes the same song, you see that one musician can play better than the other musician. Why is it like that? Because there is some qualitative way of playing the music that depends on the musician personality. And finally, when it is converted to technical description, the subjectivity is completely gone because it is recorded by machine. And the impact is that the signal becomes very quantitative, no qualitative description anymore. So let's see some example, yeah, of verbal description in the past. Verbal description to original biosignal acquisition method. This is how Avicenna, this is the father of the modern medicines, is from Baghdad, if I'm not mistaken. Ibn Sina is his real name. He described this biosignal like this. For example, irregular pulse as the flight of a gazelle, stone bullet shot out of a crossbow, scattered leaves. Angelique, can you try to mimic this sound? Can you do it?
What? I don't know how that sounds.
Yeah, you don't know, even you don't know how that sounds, right? Because you never
Yes.
see a gazelle, maybe. Or how does a stone bullet shot out of crossbow? Crossbow, you know, crossbow. Crossbow is like an arrow, a bow, but it uses this machine-like, so it is more automated compared to the bow that is pulled by hand. So see, even if it is already described like this, because we live in different time than Avicenna, we don't know how this sounds. That time, crossbow already extinct now, replaced by guns. Even scattered leaf, because you live inside apartment, for example, you live inside house, you don't have many trees. How do scattered leaf sounds? Crepitation of salts in a heated dish. How does it sound? Maybe like that, something like that. But we never know. Yeah. So noise emitted by healthy lung when compressed in the hand. So this is something, it is better rather than no description at all, of course, yeah. But it is still very subjective and difficult to reproduce. Bass note of a musical instrument, dum dum dum, maybe like that. Yeah, the sound of the heart, dum dum dum, something like that. But yeah, look, I myself could interpret it differently. The first interpretation is dum dum dum. The other interpretation is dum dum dum, something like that. Like Pak Aulia Hart is dub dub. He interpreted it as dub dub dub. So see here, different person may interpret differently. Even the same person may interpret differently at different time. Wet, dry, crackling sound. Cooing of a wood pigeon. I don't know. Because I never see any pigeon in the wood. So here, this is how the original bicycle was described in the form of verbal description. Yeah. Maybe that the culture is like that time, yeah, in the Arabic countries here in Indonesia was to very poetic. Yeah. So to write that sound even as like a poem, poetic words, very beautiful words, but very difficult to reproduce the sound. And then it gets better by using the musical note to describe the biosignal sound. So this is, for example, Marquette, yeah, in the 18th century. Write a note based on the coding of heart pulses with musical notes. In this first example, the pulse natural regular, I don't know, this is in French. Natural regulated pulse. While if you have three different abnormal pulses, this one. This is from top to bottom, this one is discontinuous pulse. This is irregular intermittent pulse. This is irregular pulse, the bottom part, rising in between the normal pulse. Any of you playing music? Siapa? Ezra, do you play music?
Yes, sir.
Can you read this musical note?
Not the B one, but the A part. Maybe I can a little bit.
Can you produce maybe with your sound? How does it sound?
No, no, sorry. I cannot.
How does it sound like? Because I don't know. I don't know. I cannot read this note. Does it sound like a normal push, normal regular heart pulse? If you look at this note,
Yeah. I think I don't know because the normal pulse is like do do, but it's like waving, right?
yeah.
The,
So dub dub is
uh,
actually the bigger part. Actually, there is a sliding part, right? If you listen to your heart carefully, it's not one big
mhm,
tap, yeah, but instead there is a dub dub, something like that, right? Like there is a
mhm.
sliding as well. Yeah, but yeah,
Yeah,
if you
maybe.
could, yeah, maybe if you try to follow them, maybe I don't know, you could use any musical instrument or using your own voice to try to reproduce this, and then maybe present it to the class next time. Yeah, so I'm really curious because I'm not musician myself, so I don't know how this really sounds. These two musical notes. Yeah. I'm curious, yeah, whether they really resemble the heartbeat regulated pulse as we know, yeah, the current phonocardiogram or stethoscope sound. It will be interesting, yeah, to see also how physicians in the past they try to describe the biosignal. Okay, let's move on. So then afterwards, physicians move to the more technical biosignal acquisition. So this was the first speakmomanometer as the first diagnostic instrument that uses artificial palpation. So artificial palpation means that it does not use hands or fingers anymore to attach to the artery in the wrist. Instead, it uses uh, this kind of tube, yeah, that it press or to the wrist, and then it feels or it detect or it sense the blood pulse, the blood pulse at the artery, and then recorded it immediately. There is no electronic yet that time, so it was done all mechanically. It was done all mechanically like this. This is something which rotates. Yeah, even this method is still used in seismograph, for example, to record the vibration of the volcano, yeah, or earthquake. The paper is rolling, and then the needle with the ink on its tip will vibrate. The vibration of which depends on the signal coming from this sensor. Yeah, signal here, and then it is reflected, and then this will move according to the blood pulse, and then this is the typical recording of the biosignal in the artery pulse. Yeah, this is the smaller version of that Speakmograph. So even then, that time they already can build wearable device and completely mechanical. Yeah, no electronic at all here. And this is called completely mechanical device. Can you imagine that? Even now, I don't know how to make such thing. So this is Speakmograph, developed by Dr. Dudgeon, Robert Ellis Dudgeon, in the late 19th century to record radial pressure pulse. So this belt will apply pressure to the artery pulse, and this pressure will be felt. The pulsating flow of the blood through the vein or through the artery will be fed by this mechanical device and change into mechanical deflection. This will deflect the needle here and with an ink on it, so that then it will record the pulsating of the blood flow. Yeah? So quite a genius setup actually for that time. This is quite a very nice invention. If we think even now, it is not that easy. If we try to reconstruct this, it will be interesting if we can reconstruct this, because this is no electrical at all, no electronic at all. So it doesn't work on battery, but maybe based on spring mechanism. Yeah? Okay, so if we then classify the biosignal, okay, so time is up. So let's first have a break. So I will stop the